Welcome back to the BC Talk. All right. What's up, guys? Welcome to the talk. It's good to have you guys. Brendan and Tom both graduated from UDPT with me, so it's good to have you guys on. It's been about 6 months now, holy cow, since we graduated. So yeah, how have you guys been?
Been good. I just started working in March and just getting the hang of things. What you,
Yeah,
Tom?
I've been good too.
What have you been up to, Tom? Where are you working at?
Yeah. So I'm working at the University of Delaware as a per diem therapist, doing some coverage while I just started my PhD as well
Okay.
in biomechanics and movement science.
All right. So I'm working for Kessler for the past 3 weeks, guys. I know both of you guys know that because I got the job offer way back in February. So, but I officially started about 2 weeks ago, May 16th, and I'm almost done training. So now I'll be in my full-time site. So I kind of got trained somewhere else. So yeah, I'm gonna officially start a caseload this coming Wednesday.
Nice.
What have you I know Brendan, you're probably working the most intense schedule.
Yeah, so I started in beginning of March. I worked for a company called Ivy Rehab. I started off, I'm still split in between two locations up here in Connecticut. I started off doing 4 10-hour days, but they're transitioning me to be full-time at the location that's a little bit closer. So now I'm doing 5 just regular 8-hour shifts. But yeah, I got pretty much a full caseload. I just do dry needling. Oh, sorry, go ahead.
You said 5 8 hours versus a 4-day work schedule with like 12 and or something like that.
It was 4 10s. So it's still 40 hours. I did 4 10s to 5 8s. But with commute and patient notes, if you don't finish them during the day, it ends up being a little bit longer hours than what you're there for.
Yeah. So I'm gonna work. My schedule is gonna be interesting. My schedule is going to be 12 12 10 8. Now I think the math might be funky. No, it's 6 10 12 12 10 6. I don't know how much I like that. So it ends up being 40. So 24 34 6. So I don't know. You guys know I run a lot. So those it's gonna be Monday, Tuesday off, Wednesday, Thursday, Friday. And he's gonna just kind of he's gonna taper. So 12 Monday, 12 Wednesday, 10 Thursday, 6 Friday. So he's gonna taper down. But I don't know. I'm gonna try to talk either for the coming weeks or month, maybe sometime down the road to work 38 hours where it's 11 11 10 6, or maybe try to shift on to working more on Friday, just because I've done some for my training 12-hour days and it just sucks.
Yeah,
my lunch breaks
those probably turn into being off days for you.
Yeah, you're not gonna want to run on those days.
Yeah, I mean, during my lunch break I take the 1 hour lunch break I have. Thankfully during my training site I have a gym next to me, so I go to the gym and I just run maybe 20 minutes or swim maybe, and that's kind of worked out. But it might be harder in my new site because I don't have a gym right next to my clinic.
Are you gonna have a 1 hour lunch when you're working full time?
Yeah,
bro, that's so nice. I get 30-minute lunches and they literally schedule me a patient 30 minutes before my lunch, so they always run over. So I literally have it's so whack.
That's not
I literally have 15 minutes to run into the back room and eat.
Okay.
Or I have to force the patient out in 30 minutes, which I don't want to do, but sometimes I just have to. I'm I need some time to just relax and eat and take a break.
So respecting your lunch hour.
Yeah.
So wait, so you work 10 10 10 10. So what's your start time? What's your end time?
Well, now I'm 5 8. When I was the 10 hours, I started, I had Mondays off, so it was nice having a 3-day weekend, but like I said, those 4 days were pretty long. So Tuesday, Wednesday, I went in at 7:30 and I got out. My lunch isn't included in my 10 hours, so I'm actually there for 10 and a half hours. So
shit, that's not nice.
Yeah, 7:30 to 6. on Tuesday, Wednesday, Thursday. Oh no, it was 8:30 to 7, Tuesday, Wednesday.
Okay.
Thursday I went in at 7:30, got out at 6, and then Friday was 7 to 5:30.
All right. So it's kind of weird they add you like an extra 30 minutes. Oh my God.
And it's so whack.
Bro, no. I'm pretty happy at Kessler. Kessler, I feel like is like the UD private way. Like it's really, I'm surprised. My notes take forever, fucking forever though, just like UD, but I'm getting quicker. But part of me likes that aspect of it, that it's similar to like University of Delaware's like standards.
Yeah.
So speaking of UD,
You'll
Tom,
start-
you said you're per diem, right? Well, I'm sorry, what was that, Brendan?
I was gonna say you'll start to make your notes shorter.
Yeah.
As you start getting the full caseload.
Like templates and all that.
I can get my daily notes done. Like if I can sit down and do it, I can get them done in like 5 minutes. The evals still take me longer, but
I'll take like 15 minutes for daily notes. No, I think like 10 to 15 because I change up so much sometimes, or maybe not even so much, but I kind of like do more than what other people do because some people just rinse and repeat very often.
Yep.
Tom, how's your evals coming along?
They're good. I guess like in terms of documentation, we get paid a little extra for the documentation time. So it's like 5 minutes for a treatment note and then 20 minutes for an eval. Is how much each of like those notes get paid extra, which is nice, especially when you have students, because then you get doubled up quite a bit. So within 5 hours you can have 10 patients and each one is an extra 5. So that's good. And then as long as you can just keep rolling, and sometimes the edits take time depending on the students, but it's good. Yeah, I like that.
You're CIing whenever you're in the clinic. You're being in.
So I'm doing both. So I work on both sides of the clinic, the SNO side and the neurologic and older adult side, which is fun. So I get to do students on both sides, and I do individual or alone time treatments on both sides, which are also a lot of fun because that's more like personal, hands-on, one-on-one, versus like coaching a student through the treatment.
Okay. So I wonder, Brendan, do you feel ready to be a CI if you were taking on that, if you had to take over that?
I probably could if I need to. We actually have a student in our clinic, one of the clinics right now from Sacred Heart. She's the first year, so she's still fresh, doesn't really know too much, but
That's true.
She's been doing really good. So there's been a couple times where I've been a little overloaded with patients and had to have her come help out, or she's been asking me questions in terms of like I just graduated, so I have a different perspective than the other therapists in the clinic. But so I think I could definitely make it work.
Yeah, I don't have any students in my clinic. There's like a credentialing thing I could do to be a CI, AP through the APTA, but
I just did that a couple of weeks ago.
Okay. Was that like over a weekend?
Yes, it was a day and a half. So it was half day Friday, all day Saturday. And it was good. So there was like a little bit of a lecture component, but then you work through a workbook, and then you have like a practical, I guess, that you need to do kind of like with difficult situations with students. So whether or not they want to go along with your plan or they don't, or like if you're in a setting that the student's not like focused on. So like the most common one, or like the example that they gave was like somebody who doesn't really want to do acute care, they want to do pediatrics, and you gotta show them the value in treating somebody or an older adult with COPD on why that applies to pediatrics.
Okay, cool. All right, so it sounds like we're all doing our own thing here. I'm going to be working with like your orthopedic patients, just like SNO, sports and orthopedic side of the UD clinic. Brennan, you're about the same page, right?
Yep.
Yeah, so we have a lot of ortho experience. So I brought you guys on to kind of talk a little bit about our kind of experiences with lower extremity injuries, starting from like ankle, knee, hip. to working our way up. And I specifically want to start with ankle because the two of you guys have massively sprained your ankles in the past 5 years or so. So, and me myself as well, I've sprained my ankle 4 different times. I actually had to take off of running for like a year because of how bad it was. Brendan, you were there when I sprained it, and that was not fun. So, and Tom, I had to pick you up from an ankle sprain because you couldn't get home. So, yeah.
Yeah, I was gonna mention that.
Yeah, I won't forget getting a phone call from you, just feeling so horrible. I was like, no. It was like picking up a friend from like an ER or something. I was like, Tom sprained his ankle. And you were with Pepper too, just like it was, you were with Pepper, your mixed.
Yeah, and it wasn't even her fault. It was just like total oversight on crossing a trail.
Yeah. So yeah, running's coming along. I raced yesterday and my ankles are good, but that was a long road to get to this point. So I kind of wanted to just chat with you guys about like what our ankle sprain recovery process has been like.
Sure, I can start with that. So like you mentioned, I've had my fair share of ankle injuries. Was a soccer player, so it's a pretty common injury in soccer, and pretty much all my ankle sprains were from soccer. I was a little bit different than you guys because I actually had a grade 3 sprain, meaning I one who's not from the PT realm, meaning I tore some of the ligaments in my ankle.
Yeah.
And
Did you
I
have a bony fracture with that?
Huh?
Did you have like a fracture along with that or not?
No fracture, but I was in a cast for 3 weeks. So I was, hobbling around on crutches.
And when was that? So was that before we learned that casting people wasn't the best
Yeah,
always?
that was before that. This was in high school, so it was like my senior year, right before college. I was at a college. I was trying to play soccer in college, so I was like at a college ID camp, and I jumped up trying to avoid a tackle, and I came right down on the guy's foot and rolled right over it.
Mm-hmm.
And it swelled up. It literally looked like I had a baseball in my ankle. I thought I broke it, but they said there were no breaks, no fractures, anything like that.
Yeah.
Did
they like carry you out?
I believe so. Yeah, I did not walk off the field. I was in a lot of pain.
Yeah, that sounds like my first ankle injury. It was coming down on someone's foot after a jump in volleyball. I don't play volleyball, and that's probably the last time I played volleyball, about like 5 years ago. Always wear a brace. How about you, Tom?
That's all I do now is wear a brace anytime I play.
Yeah. I guess like the first one and similar to Brendan, I also had some torn ligaments there. But it was we were doing actually kind of like a charity thing where we auctioned off us as kind of like Sherpas to carry backpacks up a mountain.
Mm-hmm.
And then as part of like a training session, so we like backpacked up and then dropped everybody's stuff off, and then we ran back down. And it was actually while we were running down, I was a little tired and I misplaced my foot and rolled it pretty bad, and I couldn't actually like walk. And then thankfully there was an older couple that came up and they actually lent me their trekking poles so I could use that to get down. And it was, I feel like I'm being a little dramatic, but it was kind of like 2 miles back to where the boat landing was, so that I could get on a boat to go back to where like the lodge was, and then hop in a car to go back into town, which is already a rural town. So that was a little rough there, but nothing had broken. I went to get an x-ray, and then I would think like the biggest difference between that one and some of the ones that I've had while in PT school in Delaware, one was similar to Bryant doing volleyball, was getting physical therapy versus not getting physical therapy for the ankle sprain.
Mm-hmm.
So I feel like I got a much better recovery and better skills after physical therapy here versus when I sprained it the original time was just kind of like self-recovery. So doing all of like the compression, the just like the exercises and making sure that everything's going well there, and trying to stay up with all the training, because at the time still had to train 20 to 30 hours a week. And that I kind of felt even like months later, like into the cross country season, so that was in the summer, so then even through the fall and into the winter for skiing, like I felt limited that whole time because I was super cautious about spraining it again versus, once I came in for physical therapy and we went through some of like the major things there and all the tools for like the strength, the range of motion and everything. And that really kind of got me better faster, and then better, kind of like just overall is like preventing, I don't know if I can say preventing another one, because I did have another one after that, but it was, like I was at a higher level faster.
Yeah. So when it comes to ankle sprains, the chances of reoccurrence is pretty high, unfortunately. And even though the evidence is pretty low on, or not like clear on bracing, I think it's good for if you haven't had one, but I think it was unclear on the JOSPT, like the popular journal for sports.
On the most recent CPG, that was one of the big changes. Was previous to, I think, 2020, they didn't recommend, if you hadn't had a prior ankle sprain, you didn't need to wear an ankle brace. But then after the new CPG came out, 2020, 2021, I think, they said that wearing it preemptively in, the sports like basketball, volleyball, stuff like that, was actually, they had a decreased incidence if you wore the brace, even if not having an ankle sprain before.
Makes sense.
Yeah, so that's something that I feel like is a little bit common sense. Given it's not like a neoprene brace, it's not a soft bandage that you're just bracing up. It has to be something rigid. That's something I haven't told anyone yet because I haven't had to, but that's something, if I had myself as a patient, I would have told myself, you're playing a soccer game, and like, let's have you like just brace it. You don't want to, especially like if I heard my goals back then, racing, I would have been like, hey, like, this is like intramural soccer. Kind of like, for the audience, some background on that is that during my second or my third sprain, actually, because there was another one right before, a year before that, this incident, I was playing soccer, as I mentioned. If I had a brace on for that injury, I probably would have been fine, and I would have gone on to compete that year and done really well, and been able like to get on to running a lot sooner than now, essentially. So yeah, now Brendan, I know you wear braces all the time too.
Oh yeah, I've had too many injuries. I can't really afford to have another one. I didn't mention this yet, but my last ankle injury was in a brace. This was in college.
Okay.
Undergrad. Actually, no, I've had an ankle injury since then, but one of my last ones was in college, again, playing intramurals, playing soccer, and I was on turf, and I was wearing like regular cleats, and I like the ball was going out of bounds, and I like lunged to try to get it, and my cleats went into the turf. They stopped moving, but my lower leg did, so your legs like this, and it just slid forward, and I think I basically like subluxed my ankle, and then it which is not good. So I still don't have full dorsiflexion because of that, which kind of sucks.
Yeah. So, all right. So let's talk about all right. What are you guys have seen? What's some cool things you guys have seen in the clinic, either ankle or anything else?
I've seen quite a bit of ankle. One of the clinics I work at, we get a lot of referrals from podiatrists. So I actually see a lot of like great toe stuff too, like the fusions or the bunionectomies, that kind of stuff, but then also up to the ankle. There's one patient that I'm thinking of that she was, I think, kind of similar to your injury, Tom. She was hiking and like rolled over like a branch or a root or something like that, and she's coming to PT, which is good, but outside of PT she's not being compliant. So they told her to wear a boot for a while, and then still told her like if she's doing a lot of walking and stuff, she should be in the walking boot. And like last time I saw her, she was planning on going to DC for like a long weekend, and she's like, we're just like, oh, you're gonna bring the boot, right? She's like, oh, I might bring it, but I'm probably not gonna use it. And I'm just like, you've been having it, it's been like since October, so it's been like 8 months now that she's been having this pain, and she's seen the doctor twice. She's been in a boot for so long. And like, I get not wanting to be in the boot, but like she's in all of this pain too. So I think it's definitely, like Tom was saying, if you're going to go to PT, that's the first step, but then you got to actually do the PT, do the exercises, be compliant, do everything that they're talking about, because otherwise it's just gonna kind of linger around and you can be in this pain for quite a long time.
Yeah. Tom, how about you?
Yeah, I guess some of the most recent, I guess like ankles and feet that I've seen. What surprisingly, I don't know about you guys, but like how common you get kind of like a cuboid dysfunction type thing, where somebody's walking and then you end up having to tape or do something with the cuboid bone. So oftentimes they're just walking and then they might feel something and then it just doesn't feel right, and you're like looking at the ankle, you're looking at the first ray and everything, and nothing's coming up, and it's normally kind of on my bottom of the list, but has since moved up a little bit, considering I've seen it more times than not.
Yeah.
Yeah.
What about have any of you guys seen, not maybe while you're working, but either in your rotations or at UD, metatarsal fracture, or what could it be, like a stress fracture of the first or second metatarsal? Because
I haven't treated one of those.
It's actually more common than I thought on runners. So just like a little, just so you guys can keep it in your mind, for if you get a runner or someone that's a very high level impact athlete, you can get I think second metatarsal is the most common stress fracture that you can get, and it's just from like repetitive running, and I think some foot strike tendency to land in forefoot, I think, can increase that risk. But basically, it's just you're gonna get pain on, like, once you palpate it, like once you feel pressed against the bone, like they're gonna wince. Like my sister she was starting to get pain there, and I was like immediately like, let's like take care of this, let's offload a little bit. And I actually had a friend who ended his running season early because he fractured that bone. So, and he's really good. He's like 151, 800 guy, like 406 miler. He's really quick, and he's had like a bumpy road over running overall, and that was kind of sad to hear. So yeah, if you guys catch it, it's like you hear about tibial medial stress syndrome, and then stress fractures up with that area. So like, but I don't feel like we hear about foot metatarsal fractures, stress fractures as much, or it was my first time learning about it until recently. Yeah, for anyone out there with an ankle sprain, I feel like go to PT. You might learn something new. Believe me, you don't know everything. I thought I did, and yeah, that didn't work out. You guys know I know everything, right? I know everything. Now I do. Like, it seems like we have been helped by PT. So if anyone has one, an injury of any sort, get some help. Let's go. We have 4 minutes, so let's just kind of start to dive into the either calf or knee area. So what do you guys have got there? What cool things have you guys seen?
I guess it's kind of related to the ankle, but coming in, having somebody walk into the clinic with an Achilles tendon rupture, and then having to kind of give them the education on what their options are, and then immediately getting them in a boot and plantar flexion to kind of prevent any further separation. But their paperwork will look a lot like an ankle sprain, and then you'll get there and it won't be an ankle sprain.
Yeah,
I've had an Achilles rupture. How about you, Brent?
I've not had a rupture. I've had a couple of just like gastroc strains, which I was kind of surprised about, and they recover fairly quickly. A lot of Achilles tendonitis, tendinopathy stuff.
Yeah. Have you guys ever felt like a little nodule on someone's calf to really like tell you this is a tendon issue?
Yeah.
Like, I know, like, my dad was actually the first person who I was like, why is this like little bump on his Achilles? And he's like, and I touch it and he's like, and I'm just like, oh, well, I'm sorry, Dad, but your Achilles is really fucked up. We got to address this with exercises, because all he wants is massages. This man just swears by massaging, and that's what's going to get him better. And I'm like, Dad, you're not going to just get better at massaging. Unfortunately, I wish that was the case. I wish it was that simple. But yeah, with a lot of tendon issues, as you guys know, it's about loading it and dosing it appropriately. So giving them the right exercises, frequency and amount. But yeah, I feel like Achilles tendon ruptures, tendonitis of the Achilles, that's all pretty common, or at least not the rupture part, but the tendonitis part.
And Brennan, what you said about the gastroc strains or like the calf strains, that reminded me. I had a guy who had a insert or origin tendon tear of the gastroc. So that was a fun one to treat.
Yeah.
Because it got thought of as kind of like a meniscal tear and all that stuff. Because a lot of those knee exams looked a lot of the same, but then he was kind of very stagnant in recovery and went and got an MRI, and that's what came back. So that was kind of like, sometimes we don't like imaging, but that was kind of one where it was like, oh, once we started focusing on those things, then he got much better, much quicker.
Did he have pain with calf raises?
Kind of, not really. It was much more like of a knee flexion type problem. So it was whenever the gastroc was engaged in performing knee flexion. So like Nordic hamstring curls were one of the first things that I gave him.
Okay. All right. Speaking of Nordic hamstring curls, I actually bought a portable one. I'll probably share with you guys afterwards. It's really, really freaking cool. You can put it like against the door and like kind of wedge it and then just use it. I got to show you guys. But we have less than a minute left, so I wanted we're gonna restart the Zoom session. I'll see how I send it to you guys, but I wanted to start with maybe some meniscal injuries because you kind of set me off there with like meniscus.
I have one other calf thing I want to talk about.
Go for it.
That I thought of.
Calf thing?
So just until it's calf.
Calf thing. Okay, yeah, go for it.
Yeah, like cows, calf.
Like cows. All right, sweet. I'm gonna redo
Wait
this.
till it opens so I can.
I think
Yeah, just
you think I can read? You guys can use the same one, or
I don't think so. I think you got to set a new one.
all right, I'll start a new one. And now text or email.
Email's good.
You guys
Text
like?
works better.
All right, I'll do both. I was sitting all the way back here.
I don't think so.
I don't know. It's weird. All right, whatever. Fuck it.
You're funny.
Thank you, sir. I don't try. Usually, when I try, I fail.
Sorry, I'm laughing at you, not with you.
Oh, fuck yeah.
All right, we're good.
All right, tell me about this calf injuries that you said.
Yeah,
it's
so,
a pretty interesting one.
Yeah, so I thought it for a while. I thought it was just another calf strain. But I wasn't really able to reproduce the patient's pain at all. He was having it after about a mile of running, and I think it kind of just left my brain a little bit. But he saw one of our other therapists there, and she was thinking that it's some sort of like neurogenic claudication because like he doesn't have it until like a mile in, and then it's lasting for a little while afterwards. So I just thought that was interesting. It doesn't necessarily, like, his pain was strictly in the calf muscle, and like he had some like trigger points there. Like it was a little tender to push on it, but it wasn't like his pain that he was coming in complaining about. And you could definitely feel there was like some soft tissue like restrictions or whatever in there. So some of the therapists had tried dry needling, and like he was seeing a little bit of benefit with that. It was at least like helping loosen up the muscle and everything like that. But then he went and tried to run again, and like right at a mile, he had his pain again. And I actually haven't seen him again since then. He had taken a little bit of a break, but I think he's coming back in next week. So he might.
Do you think it's his muscle tightness pushing against the nerve and that causing his symptoms?
Yeah, that's what I think there's something like that. The other therapist said she had gone up and was looking at the hip and I think she said she was like palpating his piriformis or whatever, and that was recreating some of the things. So it's like, it's not impacting him until a mile in, because that's when it's really he's starting to feel that tightness or whatever.
Yeah.
So just that one was interesting,
Yeah. That kind of brings.
We know that it's not necessarily in that area, look above and below.
It's always one of those weird things where it's a mile in and then you start to feel it, or 2 miles in and then they just can't. The pain's like limiting them. I had someone like that for the low back, not for the calf or hip area. But how about you, Tom?
As for anybody who, when they come in, it's, their pain's only when they're running for X amount of time.
Yeah, or any calf or hip or knee injuries that you've had, like kind of like goes away or doesn't go away after like onsets at about a mile in.
Yeah, I've had a couple of people like that. Oftentimes I'll go straight to looking at their form because a lot of times it'll be derived from that. So I might see them doing something kind of funky that's like, oh, after a mile, that might cause it to start hurting. And it might not be new for that, or like it might be new for them, but like sometimes it's that change in form that helps decrease that pain a little bit. So even though they were running like that before, they hadn't quite tipped over the edge to where the pain was coming on from it. But sometimes the problem is biomechanical and like how they're moving their limb, and reteaching some of that stuff. And it does take time and practice and a lot of cueing for that. And then kind of like putting all that motor learning stuff in together.
So now, when it comes to like biomechanical analysis of like running, that sounds fancy. Like what are some things you start with just at the basic level?
I mean, I'll like if they're a runner, I'll have them run on the treadmill, so that I can get a good view of behind and to the side and then in the front. My way that I go about it is typically I look at the foot first, kind of if they're heel, mid, or forefoot, and then from there I'll kind of look at the back to see what their ankle's doing, and then I can look up into their knee and their hips and then their pelvis, and also like if it's somebody with back pain, then you can look at what they're doing with their back and which side the pain is on. So like if they have left-sided back pain, and their hip is dropping on the right side, or I guess so that side is going down. I mean, that could be causing the pain, and that would make sense. So that might be the cue that I'm working for, instead of like if there's something wrong with their knee. I might not cue that, because I find like one cue, even for just exercises, helps much more than like, oh, put your shoulders back, squeeze your stomach. Like one thing.
There's one thing at a time. Yeah. Here's a little trick question for you guys. Should it matter what kind of striker they are, forefoot, heel, or midfoot? You can, like what I mean is like, does that change the risk of injury? Should you try to modify or change it if you're like, say, a heel striker?
I won't change how they strike their foot, because I feel like that's a whole different process. And if they're interested in doing that because they feel like when they're doing that, so like let's say somebody going from heel striking to forefoot striking is often the most common. Let's say like while they're sprinting, they feel really light and really good, and then that's something that they want to focus on. Yeah, we can definitely try and forefoot strike a little bit more, but as you guys both know, there's the differences in like how much strength and how much absorption has to go into the foot when they're forefoot striking versus heel foot striking. And then if they're potentially if they're recurrently getting injured in a way that is similar to heel striking, but it's often an overstriding rather than a heel striking problem.
There you go. Bingo. That's what I was hoping you'd lead there, because
I'm glad I passed the test.
you passed my test. It took you a while. I was like, oh my God, he's going on a tangent here. It doesn't matter is the simple question. But what does matter is the simple answer. What does matter is, are they overstriding? Because, and you can fact check me on this afterwards, but listening to JLSPT podcast, which you guys know is run by, with the help of Dan Chapman, they had like this running talk with 2 parts, and that was kind of like the takeaway. It's like, don't change a person's strike. It doesn't minimize or change the risk of injury. Now, if they have a calf strain and you need to take some load off of the calf, and this is a runner that decided to do the barefoot movement running, and this is what caused their injury, then you're like, all right, let's change your shoe. Like maybe land a little bit more with your heel here, just while you recover, and then kind of go to your natural landing. But when it comes overall to foot strike, don't change it much. It's just, unless there's like a specific reason to want to modify it. But overstriding is like the thing to kind of look for. And there's also other things like you mentioned already, like Trent Dallenberg, or kind of like you know, what other things up the chain. But overall, like as it comes to like that area, like that strike, then yeah. Brendan, I feel like you're not gonna look at someone running for some reason. I don't know why.
I mean, I don't see a lot of runners,
Yeah.
and running's not my wheelhouse. It's more you guys. But obviously, if you know, my plan with this guy was to get him on the treadmill at some point. We only have an Alter G,
Yeah.
so kind of seeing like it'd be interesting to see, you know, like take some of his weight off if that changes some of it. I mean, it's gonna change some of the things, but like how it changes it pretty much.
See, the Alter G.
Well, and the Alter G is much. What was that, Brian?
I said the Alter G is a fun device. Like I wish I had one or the option of having one, but not in my clinic.
I was surprised we had it.
I'm surprised you don't have a normal treadmill as well.
I don't know.
I'm great for having one, at least a normal treadmill. I'm happy I have at least a treadmill.
Yeah, I was gonna say there's a difference between like the Alter G and then getting like a harness to unload somebody, just in like how you feel while you're running, because like both do decrease the load, or I guess the vertical load, but it feels different running, and you can kind of tell just based on like, you know, everything that's kind of around your hips and whether or not the you know, like the big straps of a harness are going to affect that.
Yeah. So there's this cool invention I saw on Instagram, and it was like it's like
I was gonna say good start.
It's a good start. I was gonna make a comment on Instagram, of course. I saw it there, but it was interesting. I think it was like a runner I know that's pretty good, kind of marketing it, and basically it's like a harness, but like for runners. So you can kind of like make a regular treadmill like an Alter G, and pretty much it's just like the same concept as the Alter G, kind of lifting up from the hips, and you have like webs or bands on the side. I don't know. I might try that out. It just came to my mind, like as an addition to the clinic, as an option.
Yeah, it doesn't hurt to try it.
Yeah. I have so many ideas for my clinic. I love the fact that there's a lot of where I'm gonna work at. There's a lot of like, yeah, like if there's something you have in mind, just bring it up to the regional director, and you're welcome to go ahead and try it out, or we can purchase it. Like they're open, like they're gonna get the handheld dynamometer that we have at UD, the little push. It pretty much measures your force output of a specific muscle group. It's so funny, like the little, you know, I always die when like some people are like push. Some people like push. When it comes to like the device, like I stick to like, I don't know. I feel like I do the push, but it's just like, it does sound funny, like for someone that doesn't know what I'm talking about, so, or doesn't know what's happening. Either way, yeah. You guys have anything you guys are bringing onto your clinics? Or I know Tom, obviously you're not, but how about you, Brendan?
One of my clinics, I talked to him about getting a knee extension machine, because we don't have that. We just have a leg press. And one of them was open to it. I learned that you have to bring up these ideas at the beginning of the year, because they have like a certain amount of time and money where they're allowed to spend on more of those like bigger purchases.
Okay.
So unfortunately, the clinic that I convinced to buy it, I'm not going to be at next year. So I don't even know if they'll end up getting it, because by then, you know, I won't be there to remind them about it. But I could give a little shout out to Scott Dickinson with the Next Level. We got interest. I introduced that to actually my same clinic coordinator, and so we have that right now, and we're doing a trial run with that. And I was teaching one of the therapists, one of the aides, a little bit about it the other day, since I have some use with it at the UD clinic. But
yeah, so it's just like to help with neck injuries or neck patients. Kind of like a resistant sliding board. You can be like supine on your back and just kind of sliding with resistance your head, or rotating.
Yeah, it's really cool. You know, there's a lot more you can do than just rotation. Yeah, you do side bending, resistant chin tucks, like all that kind of stuff. And he has the Instagram page and posts all these videos of like, you know, he's got the higher level people, like the boxers and the football players, doing these crazy things that I would never do with, you know, some of my older patients. But it's just cool to see like the versatility that it has.
Yeah.
So I got to try to get my other clinic director to look at it. I brought it up to him, but then he's just so busy. He just forgets. So I might just give Scott his email and let him email him.
Yeah. I mean, all the time. We're still pretty new, but I'm sure we will convince the people we need to.
Yeah.
All right. So you said you want a knee extension machine. So kind of with that, what have you guys seen for, hip knee that you've needed to use one?
I have a guy just evaluated on Monday who has bilateral patella tendinopathy, so he would be a good one to use it on. We have a couple of ACL patients right now. Most of them are fairly fresh, so they're not quite at the knee extension machine yet, but they would be good ones to use it on in a couple of weeks. I had another person that was just like a quad strain. I could have used it with her, but again, we didn't have it. So I made do with, some Bulgarian split squats and the leg press and regular squats and lunges and stuff like that.
Yeah.
Do you ever see any knee OA, Brendan, or is that kind of like outside of your clinic?
No, yeah, I just definitely see some knee OA. It's honestly not as much as I saw at UD, which is kind of surprising.
Yeah, knee OA kind of gets.
Definitely had a couple.
That's one in knee OA. Yeah, I feel like it should be more common in the population now.
Yeah, it's like a lot. I get these knee evals and I'm expecting it to be that, but then it's like they come in with a meniscal tear. I mean, so I have some that are like meniscal tears with OA or stuff like that, but
yeah.
I
I
haven't
feel
seen
like
just like a solid OA case.
osteoarthritis is one of those things that I've always kind of struggled with because people are convinced that it's just bone on bone. This thing's not getting better. I need a knee replacement. And, if it's someone that's like worked at it before with strengthening, then sure. But yeah, some people just go for surgery right away. And it's like, we got to like at least strengthen it. Try to tell them that just because the imaging shows you something, it doesn't mean it's going to cause you pain, because lots of people do have the same level of knee OA as you. And, it's not always the reason for pain. But hey,
and it
go for it.
I was gonna say it depends on, so like if they get imaging, it depends on how much joint space narrowing there is. So like if you can like kind of categorize it into 4, and once they get toward 4, like that's when the knee replacement is I guess I don't want to say solution, but that's kind of the best option.
Yeah.
But if you're kind of in that like 1 or 2 area, like you definitely, the exercise and the physical activity is definitely what's going to get you there. And I brought up the knee OA just because like typically knee OA, hit up the knee extension and go for that.
Yeah, I think that's a lot of my education with not even just knee patients, so like shoulder, rotator cuff, knee. They'll come in and they're asking me if they need imaging, and I tell them like imaging isn't necessarily going to tell us anything different right now. And if they go in and they tell you have knee OA or you have a meniscal tear, they're not going to repair right away, or it's a rotator cuff injury, like they're probably going to send you to PT first and see if it helps.
Yeah.
So like, we'll do PT for a couple of weeks. And then if you're not seeing any progress, then that's when we go and get imaging. And it's only going to help you anyways, because we're going to get you strong. You're going to go into surgery, and the stronger you go in, the stronger you come out, and the outcomes are always better. So
yeah, that's something I might take. I might use that, because I think I haven't told anyone that, but as a like incentive, as a motivation to go through the PT and take it seriously.
Yeah.
I feel like I didn't really harp on the outcome part of it, but there's something else I wanted to mention about imaging. But if it comes to me, I'll say it. Oh, was it? I think it was about how some people just come in, because their doctors tell them they have to go to PT before an injection, or like.
Yeah.
And then I remembered what I was gonna say. So there's this person that had like with low back pain, and they asked me like, do I need imaging? And correct me if I'm wrong, but is it like okay to say, oh, like imaging is more recommended for when like you have like lower extremity symptoms with the low back, that granted this person didn't have a traumatic injury, it wasn't like he fell or it wasn't anything like I would say like you need imaging to screen out something else, but like it was more like it was presenting more as like localized low back pain, generalized low back pain. And I was like, if you had like lower extremity symptoms, like if your legs were like weak, or there's some numbness related to your back pain, then I would say imaging could be necessary. Does that sound right?
So you're specifically saying neurologic signs in the lower extremities,
Yeah.
right? Not just lower extremity symptoms, because like radiculopathy, you probably don't need the imaging.
Mhm.
But if you're finding positives on the lower quarter screen, that's when you go in. Yeah.
Yeah, because
Yeah,
I just
so
wanted to clarify that that's what you meant.
yeah, be careful with your wording there, because I was thinking the same thing. I'll have radiculopathy where we just do some extension and their symptoms go away in their legs, and that they don't need imaging for. But yeah, if it's like the lower quarter screen has positive stuff where you're seeing some of that, like the
Yeah.
weakness you were talking about would definitely be something where you would want to get the imaging.
Yeah, so like sensation changes, strength changes, and reflex changes. Those are the three things. I'm like, hey, we see something there. PT isn't working or is not helping change these things. I would recommend some imaging. Does that sound right?
Yeah.
Awesome. Okay.
Cool. Yeah. I wouldn't just say lower extremity symptoms though.
Yeah.
Have those without having them.
Yeah, that's fair. Thanks for helping me out there. I just wanted to make sure. I think I might have worded that. I could have worded that better, but that's why I'm talking it out right now, just to make sure in the future I don't. You guys know I have issues with wording stuff.
We don't need to get into that.
I don't even know if that's appropriate right now. Jesus
I don't
Christ.
think so.
What was the least appropriate? I mean, I think I could say this one. This one, there with the freaking amputee clinic. The patient, I was doing like I was just checking sensation, and I was just brushing against like their thigh just to see if their sensation changed. And I said, and I told the patient like, oh, I'm just gonna stroke across her thigh, or I'm gonna stroke you, is what I said. Very stupid way of saying anything to anyone. And it didn't register. I think I was just in the moment, very nervous. And the guy's like, what? And I'm like, oh shit. I was like, oh, I kept my cool, which I will say. I didn't like laugh, or I was like, I meant to say, like, I switched it up. But Lloyd was right next to me, like one of my friends, and he was just laughing. And the patient started laughing. And I was like, fuck, all right, whatever. Like, I didn't laugh because I was just like, I can't laugh. I kind of like, I made it pretty clear that it was like a silly mistake, but I was just like, oh my God, in my head. Yeah. So anyways, going towards the leg again. I had this interesting patient. Tell me, wait, so if there's no imaging and you guys suspect a meniscal tear, no mechanism of injury, maybe is it possible to have a meniscal tear like as a gradual onset?
I think if they have like bad enough OA, so at least this is what patients have been told by their doctors. I don't really recall learning this or or like if they have like so bad enough OA or like bone spurs in the knee, that could technically tear the meniscus, but I don't know if Tom knows any more than I do.
I guess I was just thinking of it from kind of like a mechanical perspective of like, well, what is the meniscus? What's going to cause it to tear? So like I could see having an injury that you're not aware that caused a tear, because a lot of times you might do something and be like, oh, and then you might have torn something in there, but you don't realize it because a lot of times it's asymptomatic. Or it just like doesn't affect you at all. And then it can later be found to be a tear, or like you can later diagnose a tear.
So is it possible to like then realize it like a week later and then say, oh, my knee really hurts when I was just walking out of nowhere, but you probably tore it last week or 2 weeks ago?
I guess I wouldn't put a timeline on it. I would say like potentially kind of at some point in the past you may have torn it, because I don't know when, unless they give you a mechanism of injury of being like, oh, I planted and twisted, and then I had the knee pain, versus like it was just a gradual onset of knee pain and now it's really bad and I feel this clicking in my knee that's bugging me. So like it could get progressively worse after it had already started. I could see that happening.
Because I had this patient just 2 days ago, and it was interesting. Like she said, she does Taekwondo, no strengthening program. So I'm already thinking some kind of meniscal, some kind of mechanism, possibly she didn't realize. She doesn't recall anything. And she has prior injury in that same side. So I was like, oh, it's probably some deficits, some strength deficits leading up to something. Medial joint line tenderness, like just medial joint line, nothing else. Patella's fine, everything. So I'm already listening to, she had some popliteal fossa, left knee injury. She's already saying she kind of babies it for the past 2 years, and she does Taekwondo. She's competitive, and she said she was just walking the patio and just walking, and sharp pain and swelling, some effusion actually. But no, in the day prior, she said she was fine. She was going through her classes, no changes. Granted, this is what she says. Maybe possibly she didn't notice something. But yeah, I thought that was pretty interesting. So I kind of struggle sometimes with explaining it, but I kind of go along the lines of, yeah, like sometimes we don't always know the triggers. It could have been something underlying and it just came on that day, even though like it was, it's really hard when like for someone to like be like, I didn't do anything that day, and it went from waking up amazing and feeling fine to like 0 to 10 sharp pain while walking. Like it's really hard for me to explain that to them.
Yeah, and I guess like everything just has to line up correctly. It doesn't have to be something super major. So I guess like I have like 2 examples that I think of immediately. One is like getting a concussion. Like you can get like tapped on the head and get a concussion versus like, getting drilled into the pavement and getting a concussion. Same thing with a motor vehicle accident. You could be in a 70-mile-an-hour crash and walk away totally fine, but you can also be in a 20-mile-an-hour crash and just have like ridiculous amounts of pain. So everything just has to line up correctly. I don't think the magnitude may have an impact, but it's more about all those things lining up for it to happen. So like she just stepped funny and everything lined up perfectly and it happened.
Fair. Yeah, I think I might. Yeah, that sounds right. Because I've had something similar with a shoulder patient maybe 2 weeks ago. Same thing, kind of like I was just driving and then got into the car fine. And same thing, let me get there 10 minutes. Yeah, this guy was just driving and it was just like massive shoulder pain. But he was doing like, there was like a mechanism possibly. He was doing like new shoulder exercises. So yeah, I might just say like, hey, like maybe things just lined up that day and kind of leading up to it, there could have been tears prior. And that day, just whatever reason, maybe that position just kind of led to your pain or led to this onset.
Yeah, and I don't know how old that person was, but oftentimes I like putting in like age-related changes rather than like degenerative changes or bone on bone and age-related changes, because happens to everybody. So it's not a wear and tear, it's just a age-related change.
I've had so many people tell me, oh, like I'm old, don't tell me how I'm feeling. I feel so bad sometimes.
The number of times I've been told not to grow old. Like, hey, it's better than the alternative.
Facts. All right, we have a short amount of time, so let's go to the hip. Hip injuries, anything, lumbopelvic stuff, groin, hamstring. Go.
I have a guy right now who his script said FAI, femoral acetabular impingement. And then he showed me the exercise or the x-rays, like the following visit, and he has the cam deformity. So he's got a outgrowth of bone on his femoral head. And this dude just like, he can't move his leg at all. Like as soon as like a little bit of external rotation, he's like he's jumping off the table, and then I can get him to like, I don't know, maybe like 40 degrees of hip flexion. And it's just like, it's tough. And he's like a tough patient too. He's not an easy guy to work with, but like, I'm just trying to find little activity that I can do with him that he's able to tolerate. So that
How old is this guy?
And
How old?
think he's like 30, so he's young, 35 maybe,
Yeah.
30, I don't know, something like that.
Yeah.
But like he came in the first day, he's like, yeah, I just want them to give me a hip replacement. And I'm like, what?
Oh, no.
Like, dude, you're so young. And like, that's not even what he needs. But
Yeah.
then, yeah, so that one's been interesting for
So
sure.
what stuff are you doing for treatment?
Literally whatever I can. Like everything is so painful for him. So I try to get him to do some quad sets, like that's painful. Glute sets, painful. I just told him to just not squeeze as hard. I'm doing some like a little bit of passive range of motion just until that point where like before he has that sharp pain. Have him do some like knee to chest with like with his feet on the physio ball, again trying to get some of that motion. And then I'm trying to strengthen the hips as much as I can, but it's like literally like he can't lay on his side, he can't do external rotation, he can't do like clamshells, he can't do bridges. It's like
How long does this
I
guy
started
have
doing,
for? Like, how long does this guy have pain for?
I think a little while. Like it's not something that's brand new, but it just like recently got worse.
Yeah.
So yeah, it's been
Poor
interesting.
guy.
Yeah.
I hope he doesn't need a replacement, but yeah, damn. I'll check up on you in the future about him.
Yeah, he probably is going to be there after I leave and go to the other clinic. But I tried actually, I got him on one of our other therapists schedule for next week, who's very, came from a different company and he's very into like the pain sciences and stuff like that and has a lot of background in that realm. So I think it'll be good to get him there and with him and hopefully he's able to, and obviously he has more experience too. So I don't know if there's something I'm missing that he could help this guy with that I'm not quite aware of yet.
So are they looking at like surgery, like shaving like the bony growth?
His doctor said they wouldn't do surgery, and so they sent us to PT is what happened, and he was like pissed about it.
Has he looked at a second opinion, or would you even try to go that way if you had?
We've recommended that, and I asked him about like pain management and stuff like that, but he's only seen like that one doctor. And I mean, I just started working with him, like I think he's done 3 visits now or something like that. But
how about you, Tom? Any interesting guys or gals?
So originally when you asked the question, I thought if you were asking if we had any, hip injuries, and I guess since I was little, I would say since I was little, I've had, left hip pain for forever. And when I was little and no, kind of like diagnosis or anything, got better with PT. So hip strength was a huge part of that. But then it's always been kind of like,
what kind, like you said, hip, but like specifically what area?
Like hip joint pain. So like right in the groin, like anterior medial, like right in there. So like a lot of hip, popping and clicking, kind of like throughout my whole life. Got kind of pretty bad in college with all of like the increased demand with sports and athletics. The trainers there helped me. One of the things that worked the most was actually kind of like, the muscle energy techniques. So kind of feeling for the landmarks and changing, I don't know, just kind of like how your pelvis is sitting. So that seemed to help.
Like rotating the anonymous essentially. And
yeah, so like, anterior. So like how the head trainer had said, it was like, well, your hip is, forward, it's out, and then it's like that.
So kind of working with the muscles
so
to realign, like quote unquote.
Yeah, realign. So trying to get kind of like the landmarks back into where they typically would be.
Nice.
And everything moving appropriately. Yeah. So that seemed to help. Did a little bit of dry needling. It kind of helped. It was, and so just the biggest thing was kind of like that hip strength and making sure, you're using your glutes and everything and occasionally checking it. Because then once we got into PT school, I didn't have like a positive lumbopelvic screen or anything. So
exercise is the best medicine. Like literally, like it's so simple, can really go a long way towards helping you perform and just live a better life.
Exactly. Because I was gonna say there's been periods of time where like in PT school where I've be inactive for a while.
Yeah.
And that's when it would get worse. So it was more of like the inactivity that would cause it to flare up.
Yeah, and it's pretty cool. Like with us being PTs, we can kind of self-treat. Like I had some hip flexor tendinopathy, And I was like, all right, like when I say self-treat, I mean, like, we're always gonna go to PT if it's like a bigger, wider issue. Like Brendan, I know you went for the neck, for the back. I went for my back, but for my hip flexor, I had like a tendinopathy going on. And then I was like, let me just see how strengthening goes before I go to PT. And it's been helping a lot. And it's just pretty straightforward. I found some new exercises to do to really get the hip flexor going, some stretching, and it's feeling a lot better. Can run without any like feeling or discomfort. So that's been pretty cool. Anything else?
I have one other hip thing. We see a lot of piriformis syndrome. Just that's what they get sent into us for. But like piriformis is super tender to touch, and sometimes they're like when you're doing it, they have the symptoms going down the leg. And I was kind of mentioning it earlier. I just got certified for dry needling this past weekend.
Congrats!
Congratulations!
Actually, technically, I'm not certified. I have to take the second course to become certified, but I have my certification and I'm able to do it now. But we're just not allowed to say if we're certified. I don't know.
Yeah.
Just so we have to pay more money to take the second part of the course. But anyways, so my clinic director has been doing dry needling for years. He used to teach when he was at another company, and he sees a lot of benefit with the needling and the stim. With this piriformis syndrome, really just if anyone's having pain within that piriformis, and having some down there. And so I had a couple patients yesterday actually who were diagnosed with that syndrome, but were having the tenderness to piriformis and some lower extremity.
It's a very small muscle in the gluteal like butt region, just so for anyone that doesn't know.
And so we did dry needling with them, 2 of them for the first time yesterday, and they like as soon as we were done, like they're like, oh, this feels so good. And so that's not going to be the whole treatment, but it's just kind of that adjunct to it to help with some of the pain in the short term, and then we'll get them nice and strong and hopefully get them out of PT soon.
Sweet. All right, well, we have under 30 seconds left, so I'll try to give an outro. If not, we can sign up on board again and redo it. Actually, I'm gonna just cut.
Probably gonna have to.
I'm gonna have to cut
do
it.
another one.
I'm gonna do another one, but we're just gonna do the outro there, and then when I say outro, I mean like we're just gonna say bye, and then you guys can carry on.
Bye.
They're like, all right, peace out. No, but
Dude, you need to make a reoccurring meeting so
I
you can just
know.
use the same number every time, and you don't have to create a new one.
That would be better.
Just
all right. I feel like we covered a lot, but it's impossible to cover everything. There's so much more that we could have talked about. Like we didn't even cover hamstring strains, which I kind of wish we touched on a little bit. But I mean, go to PT if you have a hamstring strain. This isn't a video to help you self-treat or to like to tell you what to do. It's just more a video of like what we've seen, kind of tell you, or for the audience, just explain that it's not simple. It's really not simple to ask someone, hey, what should I do for this specific problem via text or via conversation at a dinner party. It's just not. Like, I'm sure you guys have had questions that, seem simple. Like, hey, like, should I crack my back? Is that going to help my back pain? I'm like, I can't tell you, like, that's going to help you, because it's just, there's so much I don't know. And there's so much that goes into diagnosing and making sure the treatments are the right ones for you. So yeah, and then so this talk was about like leg injuries, and why is my dad calling me? All right, and but yeah, so I wanted to thank you guys for coming on the talk. It was a pleasure to have you guys. Really love to catch up and see what you guys are doing, and I know that we'll see you guys in the near future. I will be posting this sometime in the next like 3 to 4 weeks. I want to say it'll take some editing, but yeah, if you guys want to ever come back on the talk, or if you guys want to have any future discussions, if you guys are open to that, I would definitely love to have you guys on again.
Yeah, of course.
Yeah.
Thanks for having us. It was a fun time.
Yeah, for sure, Brian. It's always a pleasure.
Thanks, man. All right, so I will. You guys have things to do the rest of the day?
Yeah, I've got some things. I did want to add one more thing for you. I don't know, like when people ask you, like, oh, I've got this thing in my shoulder, what can I do for it?
Mhm.
I always compare it to being like, well, so if your car has a problem, you just go and ask a mechanic, my car's making this noise, and then they give you a solution.
Yeah.
No, like you typically have to take it in and they'll run a bunch of diagnostics to figure out what's wrong in order to get the solution. So that's my analogy that I use for like, I haven't, done a full assessment on you, so I can't tell you to do something.
Yeah. That's awesome, Tom. Thank you. That's a good one. I love analogies too. So I'm going to steal that one for sure. Brennan, you have not given me any single analogies, and you've been forever useless. This
Yeah,
entire
I did.
video.
I thought he did. Yeah, earlier
Did?
I thought he did.
Well, you don't remember, obviously, so it wasn't
There's
good.
the one about the imaging.
Imaging?
Yeah.
Okay.
I don't know if it's an
I don't know if
analogy.
that was an analogy as much as it was just like solid, good advice.
Yeah, and that was more like advice.
That's what I give. Solid, good advice. Thanks, Tom.
Yeah, no, I have analogies I've given to people. I just can't think of any of them on the top of my mind. But I mean, yeah, aside from like Greg telling people to do 500 quad sets a day for like for TKAs or for people that need it that aren't walking or sedentary, I can't think of anything right now. But
I like one he used. He was trying to get someone to do like, I think they were in sit to stands, and they were just like plopping down. He's like, I want you to be quiet like a ninja.
quiet like a ninja.
It was like this older lady. That's what he said to her. I thought it was funny.
Yeah, analogies go along.
But it worked. Like the next one, she was down, like didn't pop, didn't make any noise. So, hey, whatever works, right?
Mhm.
Yeah.
Works. Whatever works.
What else do you have, Bryant?
Analogy wise?
No, I was just saying, just like today or like in the
today.
call. I didn't know if you were trying to like ask us more questions or
No, that's it. The video's done. I'm probably gonna edit this out, and then as I say bye, I'll just slice that in, and that's it. Because what I've done before is just end the recording and then just keep talking, and then I'm like,
Mhm.
then it's just like, all right, we'll keep talking, but this time we're just gonna keep it going, and then we're just gonna exit when the time's right.
Hey, maybe we'll give you some good content in this last little bit. So you gotta.
Yeah,
Gotta
yeah.
keep it going.
Honestly, I feel like I've had some pretty sweet exit conversations after end the recording, and if I keep anything, I'll ask for permission if there's anything
Right.
out there. But
You should
no, it's
have some kind of like outro, like like, and it's like after you say goodbye, like this is BC talk or something, not something better than that, but like how I feel like all these YouTubers are like people who like are viral, like they're when they say goodbye, it's like something. I don't know if you ever watch Dude Perfect, but they're always like, pound it, noggin, see ya.
So I've always struggled with like, because I like personalizing my content, or like I don't want to like, and like also and I want to keep it like true to myself, and I'm not that type of person for some reason. Like I'm just like I'm like, hey, like welcome back to the talk, it's good having you. Like I'll do that.
Yeah.
It's like, all right, I'm like, so if anything, I'll probably just say, oh, like, thanks for watching the talk. I hope to see you next time. Well, I think that's what I've been doing. Just like, I'll see you next time. I'll see you next time. That's kind of what I've been doing a lot of.
Yeah, one of my favorite guys, he says, if anybody hasn't told you today, you're a legend. And then it just like cuts off. So that's Craig Ritchie.
All right.
But like, I feel like there's something you tell your athletes at the end of like workout.
Yeah.
That would be pretty good.
All right. So I need to say something that gives me, Tom, you're awesome. I fucking love you. I tell my athletes, you got this. So I will say something along the lines of, to everyone out there who doubts themselves, you got this.
Yeah, it's very motivational. And then you can put up like I don't know, some motivational thing, like you running to the top of a mountain or something. I don't know. Or if that's too cheesy, I don't know.
You can incorporate those videos you're making on your run thing.
Do you guys like the drum videos?
They're pretty dope. I'm not gonna lie.
Thank you, sir.
They're good.
That shit's gotta take so long to put together.
Nah, you'd be surprised. Like some of them are really short. Some of them, what really takes my time are these videos that we're recording.
Oh yeah.
Because I need to parse through fucking like.
This one's an hour and a half.
Yeah. So it's like, honestly, what I'm gonna do is like from now on, and I need to force myself to do it, is just post what we talked about with like mistakes and everything, like even like the Zoom outro, like everything, and then go back and on Instagram and for like a separate YouTube channel, it would just be BC Talk clips. I take 5-minute segments of our conversations and just post that. That'll save me probably a few hours of time instead of going through the hour and a half. And no, just like, all right, just picking and choosing. I might miss some awesome conversations, but just picking and choosing like 5-minute segments, maybe even less, posting them on Instagram, posting them on a separate YouTube channel, linking to this channel, and then just saying, fuck it. I probably made some blunders or, you know, like things that, you know, a lot of ums and buts or like, oh, the Zoom call is about to end, and just keeping that. And it'll save me a lot of time. And
I think that's Joe Rogan's, or at least that was his original thing. It was like for his podcasts, it was like he would just have that's why they're like 2 hours long, is because he doesn't edit them. So like that's like, I guess, a tried and true thing. I don't know who else does it, but he's very successful at it.
Yeah, no, he's really successful.
Sorry.
What's up, Brendan?
When he was saying when like if he has any blunders or anything, I thought it was funny when you were talking about like your hip and you were like going like this and saying that like the numb, and you were trying so hard not to say like misaligned or alignment and everything like that. And Brian just jumps in like, hey, alignment.
I just said this.
But he was trying, so like you could see Tom like trying to word it without saying alignment, and then you just come in and you're like alignment.
Yeah, I do that in the clinic as well. As I try to avoid saying you're out of alignment.
Yeah.
Which I was like, you know, like we like to see your landmarks looking like this. Something's not moving as well. Something, you know, might be a little more, you know, stiff than something else.
Yeah.
So it's more about movement and restriction than it is about, yeah, you're standing crooked, which is somebody with scoliosis. So like, yes, they're out of alignment, but.
Yeah, there's a lot of like things. And I don't know, I feel like some of it's like, all right, whatever. Like, you know, if they get it, they get it. But at the same time, it's like, can they over medicalize it, or is it too simple? I don't know.
Yeah, you didn't give us like a good description of your audience, because I don't know if you have too many metrics of that, but like how many of them are, you know, doctors of physical therapy, how many of them are undergraduate students, like what level do you need to like talk to?
It's like anyone, Tom. Like you're just, if anything, my job is to explain it for people that just don't know anything, like my little sister, my mom.
I think you did a good job. You know, when I'm talking about the pariformis, no one knows what the heck that is.
Yeah, I was like, all right, it's a little muscle in the back.
There's something else you did that for too.
Yeah, I kept thinking, like, I think it was for like the CI. I said, oh, clinical instructor. I said it at least twice to make sure that was clear. But I try to do that. Sometimes I look back on videos and I'm just like, could have done that better, could have done this better. And like gradually over time.
Just a lesson.
Yeah.
Yeah. Next time.
Do my first 6 videos, I fucking look back on them. I feel so cringy, but I know it's good to keep them out there just to.
Yeah, it's a learning curve to everything.
Yeah.
You should do like a video at some point where like you take clips from your first video and then like your most recent one, and just like, and then have like yourself, you know, that thing where you like show the video and you have yourself like you did for one of the debates or whatever, you know, like show it and then have the commentation, like, yeah, so you can show the progression, you can like comment on it. Oh yeah, like, you know, this is what I've learned since then, like what I would have done here, knowing what I know now, kind of thing. I think that's kind of interesting.
Yeah, I think that'll be a future thing for sure, especially as I'll roll out a couple more videos. But no, yeah.
What episode?
This is gonna be number either 17,
I think.
No. So I have a 16 that I actually recorded in November. They haven't posted it since. I haven't posted it at all, unfortunately. Those two are my former teammates. That's gonna come on in the next like week or so. This in the next coming days. It's a nutrition talk. It's gonna be super, super good for people that have like body imaging dysphoria, I think that's the word, or kind of body image issues, especially like when it comes to female athletes, or like even myself, I had that too. Distance runners tend to have that, but it's gonna be a nutrition talk. Anyone can have like a body image problem, but it would be specific to runners, and can be broadly generalized to others, but yeah, that's coming up. And I recorded another video with a friend who works for a bank, but that came out sloppy. Like it wasn't, I didn't like the camera setup, so I asked him if we could redo it. So I'm waiting on that. So this will most likely be 17th. And you guys will see it, my hope is by July.
Cool.
Yeah, so I might even post the full clip sooner. I'll see and then work on the videos, but you will see more clips from like my old videos before you see this one. Like if you look at my BC Talk on Instagram, my latest two, if not, yeah, twos, you can see like the updated look where it's like black background with the horizontal view and like the little like audio wave logo. So that's my new thing, where it's just kind of make every single video like that, short clips of it, not like the entire like 10-minute, 20-minute, 30-minute segments, and then just make it look clean. I think it looks clean to me. I'm gonna work on the consistency of how it looks, so it's like very like organized. And yeah, and then you'll see that kind of like also like the episode, what we're talking about in that clip, or is this a preview, like kind of like that? No, that's cool. All right.
You already did the exit thing, right?
Not yet,
Yeah.
but this will be it. All right. So,
Okay.
all right, everyone. Anyone in doubt? No, I can't even fucking do this. Anyone about to doubt themselves? You got this. Like, all right. All right. So, anyone out there? No, I don't like that.
Yeah.
I tell my runners this all the time. I'm gonna try to make this my outro. Even when you're doubting yourself, no.
No, I think
Everyone-
the way you were saying,
Huh?
I think you say anyone out there who doubts themselves, you got
got
this.
All right. Anyone out there who doubts themselves? See, I need to pronounce this right. Doubts themselves. Anyone out there who doubts themselves, you got this. Sound right? Is that good? Is that good?
Yeah. I think for the first one, you should say, I tell my runners this all the time, and
Yeah.
then say it. And
Yeah.
afterwards, you
Yeah.
could just do that.
All right. And so everyone out there, no, that's wrong. I keep going for this. All right. So I tell my runners this all the time, and it's usually because things like other things just haven't worked as well. This is like the thing that I feel usually works for everyone. You got this. It's pretty simple. Not too complicated. You got this. And kind of through PT school, it was helpful too. So anyone in doubt of themselves, you got this.